Hello, my name is Dr. Aadil Iqbal, and today I'd like to talk to you about our quality improvement project on the screening and treatment of alcohol use disorder amongst inpatient providers at our institution, Good Samaritan Regional Medical Center. Alcohol use disorder is a widespread health condition both in the United States and across the world, with damaging sequelae affecting many hospitalized patients and unfortunately is frequently pharmacologically undertreated. About 7.2% of patients with alcohol use disorder receive pharmacotherapy on average nationally. Naltrexone and acamprosate have the best available evidence as pharmacotherapy for patients with AUD. However, unfortunately, about 20% of patients with a lifetime diagnosis of AUD received any kind of treatment. Previous studies at other institutions have shown that discharge protocols and counseling reduce 30-day ED revisits and 30-day readmission rates. GSRMC previously had no established protocol regarding the initiation of pharmacologic treatment for hospitalized patients with active AUD, leaving a potential care gap for these patients. Our goal objective with this quality improvement project was to evaluate and improve the rate of counseling and/or pharmacotherapy prescriptions among patients with active AUD at discharge by both residents and hospitalists. To do this, we crafted a pre-intervention evaluation in which both hospitalists and residents were surveyed regarding their pre-existing knowledge and identifying barriers to counseling and prescribing AUD treatment. As well, the charts of patients with AUD were identified to establish the baseline rate of AUD pharmacotherapy. Between December of 2020 and February of 2021, we began our intervention phase, in which we delivered a series of lectures and journal clubs to both hospitalists and residents. We also distributed a series of educational flyers and crafted an epic dot phrase to assist providers with AUD treatment modalities on discharge. To assess the efficacy of our interventions, between April of 2021 and September of 2021, we resurveyed hospitalists and residents to see if there was any change in knowledge base or ongoing barriers. We also reviewed the charts of patients with AUD who were hospitalized after intervention was initiated. Ultimately, we found that a total of 47 providers responded to the pre-survey, while 18 responded to the post-survey. Primary barriers to counseling and prescriptions were noted to be a lack of patient compliance and a lack of provider knowledge. After our intervention, providers reported increased comfort with counseling patients with AUD and increased familiarity with FDA-approved medications. Prior to intervention, 30% of providers reported they had prescribed pharmacotherapy for AUD before, versus 53% afterwards. We identified the primary barrier to AUD pharmacotherapy prescriptions in the inpatient setting was a lack of provider knowledge, hence resulting in a lack of comfort counseling and prescribing these medications. We found that after our educational interventions, there was a self-reported increase in the awareness regarding AUD treatment among providers. As a result, we noted improved accuracy of documentation regarding the diagnosis of AUD in chart review. We were able to achieve a 27% increase in counseling and/or prescription of AUD medications, rising from only 4% pre-intervention to 31% post-intervention. Our results do demonstrate improved provider knowledge and increased prescriptions for naltrexone and acamprosate amongst patients hospitalized with AUD. Our results are hampered by low provider retention within the study, as less than half of the providers responded to the follow-up survey. It is also possible that providers may not be adequately documenting time spent counseling in EPIC, so our numbers may be higher than reported in this study. Ultimately, the establishment of a system-wide protocol for counseling and initiation of pharmacologic therapy for AUD treatment at time of discharge would likely result in a further improvement of the quality of care at GSRMC for alcohol use disorder.